Welcome, everybody. This is Rush University Medical Center Division of Nephrology Renal Biopsy Conference for July 28th, 2022. Today's CME activity code is 486171. Anybody needs help getting CME credit, let us know. Send us an email and we can get you enrolled. This is being recorded and will be uploaded to YouTube by Dr. Baxi. Please subscribe to our YouTube channel. You can get updates when we do upload any of our conferences. If you're not on our email list, let us know. Send us an email and we'll include you. Everyone's muted except for the faculty. So if you're not considered faculty or co-host, if you have any questions, put them in the chat and we'll try to address them. As usual, we have nothing to disclose. And the ensure patient privacy is preserved, identifying information, age, gender, ethnicity, dates, exact laboratory values, or other details have been changed to disguise the identity of the patient and protect patient's confidentiality. I see a number of new names in our audience today, so we want to welcome all these people. We're really glad to have you. Hope you enjoy it and hope you continue to come back. We have a great case today by Dr. Whittier. And I think the protocol is going to be read by second-year fellow Dr. Oliveira. So Mel, you want to take over?
Yes, can everyone hear me? Okay, so we have a patient that's 20-year-old. She's Hispanic and she had no significant past medical history. And she presented to the ER with facial swelling, leg swelling, abdominal pain, and dark urine. She had noticed that her ankles were swollen about like 1 week prior to admission, but she had initially attributed that to just like standing for long hours at work. And then over time, her swelling continued to worsen. And she developed this like facial puffiness. On review of systems, she described that her urine was darker than usual and she had been foamy, no dysuria, and was not on her menstrual cycle. She had no subjective fevers or chills. She had 4 to 5 episodes of loose, non-bloody bowel movements and reported no vomiting. She had stated that 3 months prior to presentation that she was in Mexico. She recalls a small bug bite bit her on the ankle. The area was itchy and erythematous. The lesion resolved without any intervention after several days. She described a migratory polyarthritis approximately 2 months ago that self-resolved. Her past medical history and past surgical history had nothing. She was not on any medications, nothing over the counter. Her family history was negative. She denied any history of smoking tobacco, no alcohol or recreational drug use. Her vital signs, her blood pressure was 150/110. Her heart rate was 70. She was afebrile. Her respiratory rate was 14, and she was saturating well on room air. Her height was 160 centimeters, and her weight was 60 kilograms. On physical exam, she was in no acute distress. Her lungs were clear. Her heart exam was normal. Her abdomen was soft, non-tender, non-distended. Her musculoskeletal neurological exam was normal. She did have +1 pitting edema of the bilateral lower extremities and no rashes on physical exam. Her labs, her white cell count was 3,000 with a low lymphocyte count. Her hemoglobin was 8.5 grams per deciliter and her platelet count was 90,000. On CMP, her sodium was 139, potassium 5, chloride was 109, her bicarb was 25, B1 18, creatinine 1.92, and 2 months prior, it had been normal. Her glucose was 80, her total protein was 5.5, her albumin was 2.5, her bilirubin was 0.4, alkaline phosphatase 65, her AST and ALT were normal. Her urinalysis was colorless and clear. Her specific gravity was 1.004. Her urine pH was 6.5. There was +4 protein by dipstick and +3 blood. And there were 4 microscopic WBCs and 90 RBCs. And looking at a urinalysis from 2 months prior, there was no protein. There was moderate blood, 10 to 25 RBCs per high power field. Her urine protein to creatinine ratio was 6 grams, and her urine albumin creatinine ratio was 3.1. The ANA screen was 1 to 160 titer with a homogeneous pattern. Her anti-double-stranded DNA, anti-Smith antibody complement 3 and 4 levels, and ANCA were all pending. Her rheumatoid factor and HIV were pending, and her hepatitis B and C were negative. A renal ultrasound was done. She had normal appearance of both kidneys, the left being 12 centimeters in size and the right was 10.6 centimeters in size. And then a percutaneous renal biopsy was performed.
Great, thanks, Mel. Any questions?
I'd like to just add that, she came in on a Monday, and so we were able to get her biopsied on a Tuesday just based on her presentation. So a lot of the stuff was still pending at the time of biopsy. Kind of a real-time situation.
Great. Anybody have any questions for the team? Good. We're going to start with a poll. So we have fun with this. It's always, I think, really great to get everybody engaged in what they think is going on and why we do biopsies. I mean, Bill brought up the fact that he was able to get it very quickly before we had any serology back. So what do you think this patient has? Number one is either IgA nephropathy or IgA vasculitis, an IgA-related disorder. Number two is lupus nephritis. Number three is tick bite nephropathy. Number four is ANCA vasculitis. And number five is HUS-TMA syndrome.
Somebody's got to pick. There we go. Tick bite nephropathy. Come on. I mean, that's just so good not to be. I think Dr. Robbie's probably the only one that put that the one out of 28.
I don't get to vote as a co-host.
Right.
I would have voted 5 times for tick bite.
There we go.
We got 2 tick bites.
Oh, yeah.
All right.
Well, it could be due to Lyme disease, right? From a tick bite.
Yeah.
All right, we got pretty good. A couple more votes.
Anonymous. We don't call anybody out. So
I think that Dr. Sensical may have had a case of Lyme disease with an MPGN pattern, if I remember.
Yeah, they can
Yeah,
get
also-
they can get a post-infectious GN apparently.
yeah, it
Not
was a long
common.
time ago. You're right about that. It was a long time ago. That's what we thought it was out of kind of exclusion. We had no other explanation at the time. All right. Want to end the poll?
Yep, people can see it.
Oh, I'm sorry. So we've got 20% says so IgA related disorder. 55% has in the lupus category. We've got two people bit the tick story. 1 for ANCA vasculitis, and 5 people picked HUS-TMA syndrome. So I think that's good. It's a nice mixture of diagnoses and possibilities here. Dr. Corbett, I want you to tell us what you think, and I'm going to actually, here's what I want to do, Steve, if you'll work with me. Let's go through each of these diagnoses, and you tell me why you think they're even on the list, or how they might be relevant based on the presentation. So let's start with IgA vasculitis or IgA nephropathy.
I mean, IgA vasculitis is a possibility, and she had fairly significant hematuria on a urinalysis that had been done prior to the most recent one, and it showed just my recollection was no protein, but had 60 red cells or something. She's Hispanic. You can see IgA oftentimes in Hispanics. And yeah, creatinine's up to 1.9. She's only 20 years old. I mean, it could be as a result of vasculitis with IgA nephropathy due to, by diagnosis being as a result of the IgA being seen in the mesangium. The fact that she's got essentially nephrotic syndrome, I mean, you can see that with IgA, and you can see it in vasculitis. It's kind of, in my mind, we always talk about these nephritic syndromes as less often nephrotic, but they can occur. So that's definitely a possibility. I have a hard time explaining the pancytopenia based on that. Because in general with vasculitis, unless it's something drug induced, the white count's usually elevated, not down. So to me, it's the CBC just doesn't seem to correspond for me. Lupus, I think it reeks of lupus. I mean, we got all this serology that's pending, but she's got a pancytopenia. She's got, she could have a proliferative glomerulonephritis coexisting with membranous. We've got all this stuff that's missing with the exception of a homogeneous ANA, which we can see in lupus. It's not the highest titer. What was it, 1 to 40 or something? I can't see it anymore, but
1 to 160.
1 to 160. So it's a pretty good titer. Oh, I'm sorry, I do see it now. So personally, I think lupus fits the best. Tick bite nephropathy, I mean, again, it'd be like a post-infectious GN after having had a bite. I mean, that's a possibility too. I mean, I can't say that it's not. I think you threw it in there as something kind of funny, but we don't know what the complement levels are. Maybe they're low. And maybe we'll see, an exudative proliferative GN that could be consistent with an infection-related GN post-tick bite, if you will. Ankylosing again, we don't have any of the serology. I mean, vasculitis is always a possibility, but again, for me, it's with this pancytopenia, I just can't put it together with that. HUS TMA, that's definitely possible. She had a non-bloody diarrhea, which is what you would see. Bloody diarrhea, so it'd be an atypical HUS, if you will. She's definitely thrombocytopenic. I guess, it's not a bad thought. I don't think of those patients as being nephrotic either, generally.
Well, tell me this, because you put a couple, you've said that twice now, the nephrotic part. Why do you say she's nephrotic?
Well, she's got edema, she's got hypoalbuminemia, and she's got 6 grams of protein.
Okay, she's got 6 grams of protein. That's
She's
fine. She's edematous, but
she's got an albumin of 2.5.
She's also has AKI. I mean, 2 months.
Well, I
ago,
mean,
her creatinine
nephrotic
was normal.
syndrome is proteinuria greater than 3.5 grams.
No, I'm not. I'm just making the point that maybe, she has enough AKI to explain, her edema, and if she's sick enough, her albumin may not reflect. I mean, she sounds, she doesn't sound that well. I mean,
Well, she could. I disagree.
her hypoalbuminemia could be just because she's ill.
Could be, but if you put the 3 together, it's nephrotic syndrome. She could have AKI due to the nephrotic syndrome, for God's sakes. We could go round and round on this, but at the end of the day, that's that's the definition for nephrotic syndrome. You can start trying to define it by any way you want to as to why these things, each one of these may be occurring. I mean, sure, we see a low albumin in patients that are nephritic, not because of proteinuria, but because of salt and water retention. But I personally don't think that's what's going on here.
Yeah, well, that's just the point I wanted to make.
Roger.
Go ahead, Dick. I'm sorry. Go ahead, Dick.
The history says facial swelling. I have never seen facial swelling as a consequence of AKI induced volume expansion.
So take that, Roger.
That's nephrotic syndrome until proven otherwise.
Thank you. We don't want the fellows to walk away here with some misconception.
I'm waving the white flag, if you can
The
tell.
good-natured give and take of the Russian nephrology bias.
Oh, not on this one. This was just all giving.
I'm the one that's taking those.
You're taking it.
No,
yeah.
that's a very good point. That's fine, and that's why I wanted to have the discussion. I mean, I love the concepts of nephrotic and nephritic syndrome, and I think sometimes they get thrown away because all the overlap. But I think it's a really good concept to help distinguish what your lesions are. And I wanted, not questioning your knowledge or anything, Steve. I just wanted to kind of create a little bit on that.
Au contraire.
Well,
And
Roger,
yeah.
25 years ago, this might be called nephrosonephritis because she is hypertensive. In addition to being edematous and hypoalbuminemia, but she has hematuria, hypertension, and a nephritic urine sediment. So, I mean, it's a combination of nephritis and nephrotic syndrome.
Interesting. I've never heard that nephrosonephritis term before. I'm gonna have to
Yeah,
use that.
Ed never brought that up, and he was usually one that would bring up all these terms as well. But that's a good one.
Nephrosonephritis. Okay, I like that. So Steve, you didn't use the term RPGN.
You're right, I didn't.
That's one of your favorite clinical.
Yeah, no, you're right. I
clinical-
mean, you're right. I mean, creatinine's up to 1.9. She has acute. I don't know if it's acute or chronic. I forget what was her.
It does say her creatinine was normal 2 months ago.
Yeah. So, well, she has. I would, for me, I'd have to see if this is continuing to go up or if it's just plateaued here. And if
Yeah.
it's just gone from 1 to 2 and it's staying there, then to me, that's not rapidly progressive GN. Those patients continue to progressively get worse over time. So, you're right. I mean, if I'd have been given a 1 and then a week later she was 2 and then a week later she was 3, then I'd probably use the term RPGN.
That's fair enough. I just that there is AKI here, and I think it's worth pointing out that there's this
pretty
is AKI with an
No, you're right.
It's
Well,
pretty
you're right.
important though, because we don't have that information, and if it's an RPGN, we need to think about empiric treatment. So you get this case as is now, or are you going to do empiric treatment?
Well, you don't even have to call it RPGN. If you think somebody has an acute glomerulonephritis, which you don't necessarily call RPGN, we kind of reserve that term generally for crescentic, but as you're kind of alluding to, you can see that in lupus with just severe segmental or diffuse proliferative lesions. And you're right that, whatever you call it, if you think there's an active process that's inflammatory in the glomerulus, then you've got every reason in the world to start treatment if you think it's going to get worse before it gets better. And in this setting, you're going to do a biopsy quickly anyway. So, it's not like you're going to lose a lot by starting, and you may gain something. But yeah, I mean, you're right, Roger. For me, I kind of reserve that for patients that have a rapidly progressive course, I guess. And in this, we have a couple data points.
You've got one data point. Yeah, I think that's fine. That's a good point. I just think that it's
God damn, what did I do today? I'm getting like busted out all over the place here. Sorry for the curse word. Pravir, please edit that out.
We've got a special app for that. It's called Corbett Cut, and it just takes that.
Exactly.
It just automatically picks those things up. In fact, we ought to have one of those buttons. When they do these things live on radio, they've got a drop button because they always.
Well, I didn't just use my favorite word, so at least.
Yeah, well, we know what that is. You've used it enough, so. So yeah, but I think it's there's a lot of AKI associations with GN. There's renal vein thrombosis for one possibility. Very very unusual. We see a lot of ATN in our GNs, which I've never understood, and I've never even seen it written about. But boy, it seems like GN must be some kind of a predisposition for ATN, because it's not unusual that we'll see coexisting ATN. But Steve, if this is IgA, I mean, we'd be talking probably about a crescentic IgA, no? I mean, because creatinine's up, or another cause of AKI and IgA nephropathy.
Yeah, we see all the tubules
casts.
plugged up,
Exactly.
with red cell casts.
That's true. Good. Yeah.
I mean, I think Lee Hebert and the guys from
Ohio.
Columbus, Ohio, kind of popularized that whole thing.
Yeah.
But yeah, that's right. I mean, not everything that causes an elevation in creatinine is a crescentic GN or vasculitis.
Yeah. I mean, in the old days, my old days, which are not as old as your days.
Oh man.
Now that's the thing. It's
That
certainly not
hurt.
as old as Dr. Glassick's old days, but
3 years apart.
there was a time when crescentic GN and RPGN were synonymous before we really realized, didn't make the distinction very well that that one's a pathologic term and one's a clinical term. And I think I've done enough about that.
I was just going to say, Dr. Glassick knows more about this than any of us put together. So
yeah, well, Dr. Gashty, what do you think's going on? The HUS TMA was pretty poo-pooed. Do you think that should have been that easily dropped?
Well, I think the ANA positivity with all the pancytopenia and just how she presented with 6 grams of proteinuria, all of those things, I think to me fits lupus the best. I guess that's why you do the biopsies, because you can't really rule out either HUS, TMA, or IgA. But if you really look at the case, the presentation, the cell counts being down, which is a very common lupus feature with anemia and everything, I think this is probably a lupus nephritis. And I guess one of the points that wasn't discussed was how her creatinine is almost 2, and in a 20-year-old to have a creatinine of 2, usually we see actually necrotizing lesions in lupus in young women, and their creatinine is 0.9. They have very active serology, very active UA. And for her to have a creatinine of 2, this has to be a pretty bad GN. So if I had to put my money down, I would say this is going to be a pretty severe crescentic glomerulonephritis from lupus. The 6 grams of protein, she could have a membranous lesion on top of it. She could have just an abnormal elevation in creatinine because she's in AKI and she's not excreting, abnormal elevation in her UPC because her creatinine excretion is low and the ratio is high. But I really think if her albumin is 2.5, she's putting out 6 grams, she could have a membranous lesion on top of it. but I
And
think
we
she
go-
has lupus.
We go over this a lot, and that when we see a lot of proteinuria and what we think is a case of lupus, we always say there's going to be a simultaneous um, class 5 lesion. That's not that simple, is it, Bill?
No, it's not. Yeah, the segmental lesions, the diffuse proliferative, the membranous, all can have nephrotic range proteinuria, and even podocytopathy, isolated in the setting of mesangial, can have it too. So, and unfortunately, the degree of proteinuria is not predictive of which lesion you're going to have.
And if you had 20 grams, you'd be surprised if you didn't have a podocytopathy or a class 5. Is that fair?
I think there's trends on degree of proteinuria, just as there's trends on degree of serology. For example, the diffuse proliferatives may be more hypocomplementemic than the segmentals, which are a little bit more polyimmune. And it's the same thing with proteinuria. I think if it's a very high amount of proteinuria, then you're going to usually want to think about podocytopathy or membranous, but 6 grams is well within the realm of any of the lupus lesions that we just
we talk about it all the time, but we always fall into that trap, and it's just the kind of the way we're used to thinking about. And we see a lot of obviously 5 and 4s. Dr. Glassick asked the question in the chat: if a Borrelia serology was greatly elevated, would a kidney biopsy been required? I don't know the answer to that. I think that we would have all biopsied hers because it's so unusual, and we don't have the confidence and the experience to only do that. But I think it's a good question. With that in mind, Dick, I know Bill always likes to say my 1, 2, 3, 4, and 5 are whatever. And Dick, do you have a 1, 2, 3, 4, and 5? Is it all the same thing? Is it lupus?
Well, I think the pancytopenia and the patient's sex and age and the history certainly are probably most consistent with lupus nephritis, but I'm really concerned about that that bite and the pancytopenia, which seems out of proportion to everything else. And I must say, AKI and nephrotic syndrome with lupus nephritis and a negative anti-double-stranded DNA and normal complement levels,
Dick,
a little bit on the unusual side.
Dick, they're pending. We don't know what they are.
Oh, I'm sorry. I thought
Yeah.
that they were normal. Okay.
No.
Fault.
Everything's
Okay.
all that stuff's pending. Bill was a magician and got a biopsy before anything came back. So
Right.
just like every day.
yeah, exactly. Even on a Christmas Eve, he would have it by the next day, the biopsy. Okay, I think it's time to read the biopsy. I'll spin the wheel. Kelly, Dr. Schlattman, second year fellow, will read the biopsy.
Kelly, are you going to use Melanie's computer?
Yes, I'm gonna
Okay,
use
okay, perfect. All right, good. 1 second, I'll give you control.
Oh, just change. I have to set it.
Okay, give me a second here. Hello. All right, you should be able to. All right, go ahead and click on the screen now. For Mel. Yep, and then you can use the arrows at the bottom.
Perfect. Okay. The first slide we have here, we see one core. It's the trichrome stain. With this stain, we're looking for chronicity. Just looking, at the core itself, I do think it's a pretty good sample. Down here is the medulla, and then up here is the cortex, I believe. We do see some gloms. I don't see a whole lot of blue staining material. The tubules themselves look pretty tightly packed. I don't see it, so I don't see a lot of scarring, is what I'm trying to say. I don't like outright see any like fibrosis or like crescents within the two glomeruli I see up here.
Okay, yeah, I agree with you, Kelly. No significant fibrosis. We'll go on to see the glomeruli.
Okay,
to move
perfect.
things along.
Okay, so here we have an H&E stain. We have what I think are 4 glomeruli here in view. They appear very full. I think what we're seeing, so I'm just going to pick one glomerulus. So I'm going to pick this one over here. So like I said, very full of cells. I think what we are seeing is endocapillary proliferation. No like crescents on any of these glomeruli that I see, nor do I see any karyorrhexis or anything like that, but just like a lot of endocapillary proliferation, I would say.
Yeah. So does it look like a focal or a diffuse process, Kelly?
It looks pretty diffuse to me.
Yeah. All the glomeruli are involved. Yep.
And just to make the point, we've kind of changed that terminology from endocapillary proliferation to hypercellularity, because the proliferation infers that they all come from internally in the glomerulus, and it's probably a lot of these are infiltrating cells. But we still use that term, and it's probably written. I'm just making the point for today.
I mean, while you're at this, David, I mean, does it look segmental or global, Kelly?
Well, I think global, like it looks pretty diffuse. Yeah.
Yep.
Yeah. Okay. Okay, so here we're looking at 2 glomeruli, same stain, H&E. And here we're kind of seeing the same thing, lots of hypercellularity. I don't know if, I don't think I see any karyorrhectic debris here, or like active necrosis.
Right, where the pointer is, that's all mesangial expansion, hypercellularity, mesangial deposits, giving it that bright pink eosinophilic material look. Yeah.
Okay.
Yeah, and then on the one on the right also, chock full of cells and infiltration.
Yeah.
Do you see any inflammatory cells, Kelly, or David, for that matter?
Meaning polys.
Because the one on the right looks like there might be some, but that may just be me.
Oh, maybe like here?
No, I'm looking up closer to the top periphery. There look like some multinucleated cells on the left there.
I do see it's a couple occasional polys. Yeah. And then on the glomerulus on the left over at 7 o'clock. Yeah, 7 o'clock.
7 o'clock.
To the right a little bit. To the
here.
No,
maybe.
and then down.
Down.
There it is.
Okay. Okay.
Ding 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 ding.
Yeah.
Yeah.
All right.
Okay. And then we'll go to the next slide.
Okay.
Hmm.
Okay, so still on the H&E stain, closer up view of what I think is a part of a glomerulus, and these are like capillary loops that like are open, but the like actual GBM is pretty thick.
Yeah.
Thick.
Yeah. So in the setting of lupus nephritis,
pardon?
In the setting of lupus nephritis, Kelly, what do we call that?
Yeah, the wire loops.
Yeah.
Okay.
And then how about that pink blob there at 3 o'clock? What do you think of that?
Here.
Yeah.
What do I think about that?
So is that intracapillary or extracapillary in Bowman space? Yeah.
It's kind of hard to see, but I mean, I maybe it's part of the actual wall.
No, yeah, so it's within a capillary, so so
In a- okay.
yeah, intracapillary. And then see how it has the same material as the deposits in the mesangium and glomerular basement membrane. So in the setting of lupus, we call those hyaline thrombi. They're
Oh,
intracapillary immune aggregates.
okay.
And then the rest of the glomerulus has a lot of endocapillary hypercellularity, like around, 8 o'clock, where the capillaries are full of cells.
Yeah. Like around here and here.
Yeah, right there. There's no open loops to that area where you were. Yeah.
Even up at the top, right?
Yeah.
Yeah. Yep.
It's pretty active.
Okay, moving on to the PAS stain, 2 glomeruli here. So focusing on the glomerulus and on the left here. So we see that we see some mesangial hypercellularity here, up at the top. And then maybe also like somewhat down at the bottom as well.
Yeah, it's expanded. Also, you have more, peak material matrix in the mesangium and kind of that bottom portion where you are. I mean, there's hardly an open loop there at all. So really a dense area of endocapillary hypercellularity and infiltration by cells, including the capillary lumens.
Okay, is this the hilum here?
Probably, yeah, it looks like the hilum.
Probably, okay.
Kelly, we're gonna move along a little faster because we
Oh,
have a
yeah.
lot just because we have a lot to discuss, so.
Sure. Okay, we're moving on to the Jones stain, 1 glomerulus in the center here. We're looking for any breaks in the GBM at all. I don't see any breaks outright. We're also looking for any spikes or holes in the GBM that would suggest like a membranous lesion. I'm terrible at doing this, but I don't see anything. Let's see.
Yeah, actually, if you go over to 3 o'clock, Kelly,
Yeah.
keep going over. There's an open loop right there. Yeah, and then look to the capillary wall to the right of that. There's duplication and mesangial interpositioning right there. Yeah, do you see? You have a double layer of a basement membrane. Yeah, and those nuclei there. Yeah, that's all a big duplicated loop.
With nuclei, extending from the mesangium into that space.
Oh, okay.
Yeah.
Yeah, wow, okay.
Yeah, so focal double contouring on the Jones stain. Okay, we'll go to the immunofluorescence next.
Okay, diffusely positive for IgG. Looks like everywhere, mesangial and actual GBM as
Capillary
well,
walls.
right?
Yeah. Yep.
Sorry, capillary walls, yeah.
Yeah. And the
Um,
capillary wall looks kind of
Granular.
granular. Yeah.
Yeah. Okay, moving on to the EM. So here we have the GBM. Then the podocytes are on this side. We have the lumen of the capillary here and the urinary space out here. So we're looking for any deposits, electron dense deposits. So following the GBM itself, I'm just gonna go down. Okay, so like maybe, are these deposits down here?
Yep.
Okay.
Yes.
Okay, so these are a bunch of deposits down here. And then,
We've
Yeah,
got
those are
3 slides.
mesangial deposits.
like down here where I'm actually at right now.
Yeah, that's
And
a big expanded mesangial area, mesangial deposits.
Okay, and then over here is also mesangium,
Yeah.
correct? On the left, okay. And
Yeah.
then all of these are dense deposits as well.
Yep.
You may have already said this, but if you go where you think, I mean, it's hard to see the capillary loop here because there's so much endocapillary hypercellularity. But
Yeah.
if you go over to that capillary wall and follow it, where do you see the deposits? Keep going up, go up the other way, go up, keep going up, right there. Where would those be?
These guys.
Yeah,
These right here,
yep,
subendothelial.
exactly.
Okay.
Yeah, in fact, we'll see a
Okay,
higher power of those next.
Okay. Sorry. Okay. Oh yeah, so closer view. Oh, okay, I see it much better now. So like these are all sub endothelial.
Yep.
deposits. Okay. Okay.
And then
Um,
over to the right, we have mesangial deposits over there.
Okay,
Yep.
here. Yep. Okay, got it. Okay. And then the actual like foot processes themselves, yeah, there, I mean, I would say like there is some flattening, but it's not as effaced as I've seen on other, I guess, biopsies, but
It still looks probably the 90% effaced to me.
It's pretty bad.
okay.
Yeah.
It's pretty bad. Okay, good. Okay. And then the actual capillary wall. So 298. I'm trying to remember.
Yeah, you know, this measurement's misleading because if you were to measure it down where the deposits are and there's some mesangial interpositioning, it's, you know, 1,000 nanometers. So kind of don't pay much attention to the measurement here.
Oh, okay.
Yeah.
Doesn't mean the same thing as like diabetes. I mean, this is a result of the immune complexes that are deposited there.
Yeah.
Okay. Got it.
Yeah. Yep. Reduplication as well.
Yeah.
Okay.
Definitely.
And then on to the next slide.
On to the next slide.
There you go. Yeah, now here we have some, look at around 3 o'clock up to noon. What do you see there on the outside? Yeah,
Right here.
yeah.
Okay, that's another deposit, subepithelial.
Yeah, now we have subepithelial deposits.
Okay, got it.
as well.
Okay.
Yeah.
And they're big. They're almost hump-like. I mean, they're kind of unusual in it. You know,
And here, okay.
yeah.
Okay, yeah.
Yeah. And then we have a neutrophil filling the capillary lumen there. That's what that cell is with the nucleus.
Like here? Like
Yeah.
where my mom says, okay.
Yeah.
Okay.
Yes, there was a focal TRI in the endothelium as well that I don't have a picture of.
Okay, so we had IgG positivity in the immunoprofile.
Oh yeah, so Kelly, we had full house. I didn't show all
Okay.
the other everything,
I
but
was
we had
like,
full house. Yeah,
Okay.
full house and C1q positivity.
Okay. Okay, so that points more towards a diagnosis of lupus nephritis, and it would be a class 4 because all the glomeruli that at least we saw were involved.
Yeah.
And then we had subepithelial deposits as well. So that also would indicate that there was a membranous component.
Yeah,
In a class
that's what I
5.
said. Class 4 and class 5.
And
If you-
Bill might even add podocytopathy. He can comment on that later. 'Cause,
Yes.
you know, he may comment on that later. I'll just leave it at that. So, yeah, great read. Really nice pathology. You know, we see a lot of lupus. We have not been doing them a lot in conference for various reasons, but we see a lot of lupus nephritis at Rush. And, you know, more often than not, we see more of a pauciimmune picture. We don't get to see these large, you know, wire loops. You're not going to find a better wire loop than that. These massive subendothelial deposits. It'll be interesting to see what the serology does show. We always feel like they correlate as an immune complex disease, but they don't always correlate. Dr. Corbett, you know, we were brought up in an era where this patient got oral Cytoxan, end of discussion. And then MMF came along, which Dr. Lewis would call Cytoxan light. How would you treat this patient? He never really embraced MMF for lupus nephritis. How would you treat this patient, Steve?
Can we at least hear what the serology showed?
Yes, her double-stranded DNA was greater than 300. Her C3 was 22. Her C4 was undetectable.
And ANCA, I assume, was negative.
Yes.
Not that she had crescents or anything, but she did have some, she definitely had active lesions, but
Did you get cryos by chance?
We did not.
we saw it right there in that one loop that was plugged up.
Is that really a cryo? I mean,
No, but they, no.
no, I know what you're saying, Steve. I wasn't not trying to be.
I mean, you're probably
That's
right. I
what-
mean,
that's what you could
Ed and
see.
Jimmy Roberts years ago wrote a paper about lupus patients have type 3 cryos. It's not uncommon to find them. And in fact, we didn't see it here, but that's probably what accounts for the fact that you get thumbprints in the deposits that we usually see. And I don't think David pointed that out, so I don't know if we even saw it, but it wouldn't be surprising if there was a low-level cryo for sure. But
And the reason I brought it up too is the undetectable C4, which is
Yeah.
sometimes an in vitro phenomenon. So, Steve, how would you treat this patient? We've got 4 minutes.
all right, I would, truthfully, I'd still go back to high-dose steroids, and I would talk to her seriously about cyclophosphamide, MMF, and then rituximab. I know Liz Lightstone has been a big proponent of rituximab in women because of the concerns appropriately of steroid toxicity, but this is not something to mess around with. And I guess maybe that's just, I don't necessarily, even though they all seem to be somewhat co-equal. I mean, the MMF in the TAN study was as good as cyclophosphamide, but they got cyclophosphamide for 6 months, which was a lot longer than what we gave it for. But truthfully, I kind of cling to the things I'm most comfortable with, and I still would probably give a couple of months of cyclophosphamide and steroids, along with, the usual things, Bactrim, PPI, et cetera. But I would have a discussion with her and give her an option. I mean, it wouldn't be wrong to try MMF, and it wouldn't be wrong to do Rituxan. But in all honesty, this looks bad to me.
Yeah, you know how I feel about having a discussion. I think I'm all for getting patients involved, but I don't know how. I personally think you have to tell the patient what you think should.
No, I mean, I'll give them my recommendation and tell them what the risks and benefits are.
And what
but
is your recommendation then?
What I just said, cyclophosphamide.
Okay.
and prednisone.
Okay, Dr. Gashty, what would you give her?
I would give her induction MMF high dose prednisone.
Dr. Rubin?
I agree with Steve.
Dr. Glassick?
Oral cyclophosphamide and high-dose steroids.
Interesting mix. I'm kind of, I've always personally felt that, I don't know if MMF has ever been shown to be Cytoxan light or not, but this patient, to me, because of the fact that there's no necrosis and there's just a lot of cells, and I have a feeling that this could just kind of melt away pretty quickly with steroids and MMF. This is one where I'm with Dr. Gashty. I think I'd be very comfortable giving MMF and steroids, but we'll see. We'll see what Bill did. If anybody else has a really strong opinion about one over the other, has a good reason for that, please put it in the chat. Bill, you want to take over? You're muted.
Hopefully everybody can see my screen here.
Yep.
You
You want to put it in presenter mode?
Yeah, that's what I'm trying to do. There we go. So this was what we decided to do was we discussed Cytoxan with her, but she's very young. She still definitely wanted to have a family, and not that the limited amount of oral Cytoxan that we usually give or even the Urolupus precludes that, but it does make it a little bit higher risk. And certainly sometimes if people go on to have such bad AKI that they lead to dialysis, so that's a heck of a thing to have a baby when you're on dialysis too. So, but regardless of that, we opted to give her MMF and Solumedrol. I treated her empirically with IV Solumedrol before the biopsy, and then we transitioned her to MMF and prednisone. Her course was the blue line is the creatinine, so she really did have normal creatinine in May, and then when she came in, she was 1.9. She got all the way almost up to 3. And then the steroids and the MMF kicked in, and her proteinuria gradually started to improve, and her complements didn't normalize yet, but they're getting there, and her double-stranded DNA and everything was improving. So we were very, very happy with this response. And again, these aren't exact dates or exact figures, just to protect her anonymity. So there's a lot that we could talk about with lupus, but what I wanted to kind of talk about was the classification itself. I could go into trials of therapy, or we could talk about prognosis or all sorts of things. But I think that the classification along the way has sort of lost itself. And I think that the reason it has happened is that somewhere along the way, prognosis became somehow the defining feature. And prognosis is really a feature of staging systems, not classification. So I was looking at the definition of a classification. That's that. It kind of defines different diseases. There's a classification of leukemias or thyroid cancers or whatever, and you have your different leukemias in there. So you'll have your CML, CLL, ALL, et cetera. Staging system, though, is really based on the prognosis or the severity. And so it can be in colon cancer, how far is it spread? And somewhere along the way, the lupus classification, which defined each lesion as its own disease, started to mix the lesions together because of arguments about prognosis. And so I just want to go over the three main lesions. Membranous is a whole separate story. Podocytopathy is a whole separate story. We're not really going to get into that. But the three main lesions that I want to talk about here are the old WHO class 2, which is mesangial. And here's your immunofluorescence, and that's what that would look like. Here would be a segmental lesion, which can be segmental here, or it could even appear like global if there's more than 50% of the tuft involved. And often this just has background mesangial as well, right? So this is, even though there's mesangial deposits there, this is still considered to be a pauci-immune lesion. And I think that's also where a lot of confusion has been created, because, you know, for the prototypical immune complex mediated disease to have a classification that doesn't have immunofluorescence in it is sort of laughable. This is a very separate lesion. This is the old WHO4, which is similar to what our patient had here, where you have wire loops, you may have hyaline thrombi, and your immunofluorescence is very, very different than the mesangial that we saw in the 2, or the background mesangial that we saw in 3. And we know that background mesangial is really clinically inconsequential. If you have only your mesangial lupus patient, then your extrarenal manifestations are guiding your therapy. So the fact that the background mesangial is there in 2 doesn't mean that's clinically the relevant lesion. It's the segmental necrotizing pauci-immune lesion, which is the destructive lesion. So at one point, it was thought that these could be a continuum, where you start with 2 and then you go to 3 and then you go to 4, but it's well known along the way that you don't have to have that. You can have a patient with pure 5 membranous, or you can have somebody who comes in with this as their first defining feature with it, which is her diffuse proliferative, where she was here. And so you can have your mesangial, which is the green stuff here, but you can have a pauci-immune necrotizing lesion that leads to a crescent, and in the absence of deposits there, and they can just have background mesangial. And that doesn't necessarily lead to the 4, which is the wire loop lesion. So it's pretty clear that these are very, very different lesions pathogenically.
So before you go on, we have
Sure.
to give credit to the artist here, right?
Which is who?
Ed. These
Yes.
are Ed's pictures. Ed drew these out years ago and created this. He always loved drawing things. And actually what he was trying to show is exactly what you're talking about, but that arrow there basically suggests that it doesn't go from one to the next to the other. The arrow is basically his way of saying it can go right from mesangial to DPGN.
That's right. Or it can go straight to DPGN without mesangial, or it can go straight to segmental or straight to membranous. There's not a continuum. And in each lesion, in each diagnosis, there can be prognostic variants of that if more are involved, et cetera. But the problem and this was actually pretty well known even back in 1982, where Churg wrote, it is uncertain whether focal lupus nephritis, as defined by the same immunologic mechanisms as mesangial and diffuse forms, because in some instances, immune deposits are absent from the focal lesion. And that's kind of really what we're talking about here, is that this segmental lesion is really lupus vasculitis. It looks like ANCA-vasculitis. It looks like your IgA vasculitis. It's pauci-immune. It is vasculitis, which is very different than the classic immune complex lesion of number 4. But because the prognosis were looked at, I became all this mixing and matching. And so one of the main parts is that immunofluorescence, I think, should be part of the future of classification. But what happened, because some people thought this prognosis was worse and others thought this prognosis was worse, is they started to mix the 2 together and said, let's take your patients with a lot of the glomeruli involved and a lot of the tuft involved and make that a 4, even though it could have been a pauci-immune lesion. So this became a problem, because over time now we're starting to mix our lesions together based on the staging and the prognosis as opposed to the classification of different lesions. Okay, so in the old days, the segmentals were the necrotizing pauciimmune ones, and this was the proliferative, and this one was the immune complex mediated one. But suddenly, if you had a very severe segmental with a lot of involvement, it became a 4. And then that really became a problem, and it really became this, okay, which is what Mel Schwartz's slide, which is now we're taking different diseases and putting them in the same class based on a staging process, which it's really not a stage. So it really did mix up our apples and oranges. And now, to this day, when we're treating lupus, we don't really know if one drug is particularly good for one class or not. I can't imagine that when I did fellowship to the point of now that we don't have a more defined treatment for pure membranous lupus or for pure immune complex mediated lupus or pure lupus vasculitis. So this is why it's important, because I think we could take mirror what they've done with MPGN. So of course in MPGN, as everyone's very familiar, I mean, in the old days, it was everybody with an MPGN pattern got aspirin and dipyridamol, and there was nothing really else to offer. There wasn't anything that worked. Okay. Thanks to Fervenza and CEPI, they decided that really, why don't we start categorizing these lesions based on the immunofluorescence? That'll guide the physiology, that'll guide our therapy. And now we know you can have a C3GN, you can have your immune complex mediated MPGN, you can have and it's all defined by the immunofluorescence. So I think for the future, so that we can actually get some more targeted therapies for each lesions, which are clearly pathogenically different, this is what I would propose as the new pathogenesis. Now, there's a lot in this, and we're not going to get in, like I said, into the membranous or the podocytopathy. I can bring that back to a different conference. But I think what we really need to do is kind of go back to the point of keep this as a lupus vasculitis. And it can be even called that. It can be called a 3 as a lupus vasculitis. And then the wire loop lesion, or the one that has the wire loops and the immune aggregates endocapillary, should be there. And there's nothing to say that you can't have more than one lesion. So just like with today, we had a membranous with a wire loop lesion, you could have a membranous with a lupus vasculitis. You could have you could even actually have a pauciimmune with necrotizing lesions and wire loops in it, and you would call that a 3 and a 4. So I think that it just makes sense for future of our targeted therapies, because there's more and more therapies come out. I mean, possibly a anti-complement therapy might work in 4, but it might not work in 3, or possibly, membranous should be treated, directly with Rituxan as opposed to Cellcept or something like that. And so right now we have Cellcept for all, and we're never going to be able to figure out a difference if the classification itself isn't straightened out first. So that's kind of what I wanted to talk about. And this is sort of my future classification if it were up to Bill Whittier, which of course it's not.
Well, I put in the chat, I see the Whittier classification coming, and indeed, you didn't let me down. But I think it was kind of leading on to that you wouldn't have left it open like that. So, Bill, you would say someone could have a 2, 3, 4, 5, or 2, 3, 4, and a 5.
I would almost everybody's going to have the 2. So that I want to include. And so, and that says this here, you can have background mesangial in all of these. And since that's clinically not that significant, I would reserve the mesangial for when it's mesangial alone. But yeah, you could have a 5 and a 3. You can have a 5 and a 4. There's different, and for that matter, we should be targeting the wording of it, and necessarily not the numbers, and also try to target the cells. We could have a pauciimmune one, which also has a podocytopathy.
Mm-hmm.
So maybe the podocytopathy will fetter out in trials to have a specific therapy. Maybe complement inhibitors work for podocytopathy, but Cellcept doesn't, or something like that. But we'll never know if it keeps mixing up apples and oranges based on staging. And so the key is that it is a classification and it's not staging.
Yeah, and I think wherever you take this is fine. I think you're making a very good point. I mean, you could have a 3 with a little p. You could put the little p for the podocytopathy if you wanted, because
Right.
That's all part of these and may or may not influence therapy. But always the concept that 3 to 4 was defined not by the lesion but by the percent, which is your whole point here. That always bothered me, and as though 30% of a segmental lesion is not a bad lesion, and maybe the real world people treat a 3 and a 4 the same way, and maybe then it doesn't really matter, and maybe there isn't, but what you're proposing is that if we define these things better, we might be able to target our therapy a little bit better. I mean, it almost reminds me of IgA, you could take it like a MES score too, and have subsets of each of these, or within it. Maybe I'm mixing apples and oranges, but yeah, no, I think that's really
exactly right. You can comment on the tube interstitial disease that I have there. You can comment on the crescents, you can comment on, if there's segmental necrotizing lesions, and then that would, define it as a 3 versus the immune complex one is defined as a 4.
I know not everybody's bought into this idea. We've been the strongest proponents that Steve had brought up that, Dr. Bahar, our fellow, had kind of shown that we found at least a different prognosis when patients had significant possible.
Actually, it was Najafi.
Oh, Chris Najafi. Yeah, thank you. Sorry. They had different lesions, different prognosis based on that kind of pauci immune, more of a vasculitic lesion. Not
We had the
everybody's
hardest
bought
time
into.
getting that paper published because at the time, no one would accept the fact that a focal lesion did worse than a diffuse lesion. I mean, that was like the biggest stumbling block that we had. And I forget who the editor KI was at the time, but we kept going back and forth on that.
Well, I know not everybody's found that patients with that lesion do necessarily worse.
I can give you all kinds of explanations as to why I think that is too. But Gary Hill was one of the ones that came out after the 4S and 4G paper, after they reclassified lupus in I think it was 95 because of this study and a few others that's when they broke it into 4S and G, which was the real hope of that was we would see whether or not patients with S, which were the more pauci immune, and 4 because there were greater than 50% of patients have a greater than 50% of the glomeruli had these segmental lesions, whether they had a similar outcome as the immune complex mediated ones, which tended to be, as Bill said, more diffuse and global, or actually more global as opposed to focal. So, and Bill kind of got into some of we've written tons of papers about why we felt these things came out differently, and it has to do with how they lumped the segmentals into global if they had more than 50% of glomerular tuft involved with a segmental lesion. I mean, but
and if there is that severity, that's fine. I mean, you can be severe in 4 and have a severe immune complex 1, or you can be mild or severe in vasculitis. You could have 80% are affected with crescents, and then that one would stay as a vasculitis, and the immune complex one would stay as a 4, and then you can have you can put out prognosis later on. But the real problem was it just mixed them all together, and suddenly the severe segmentals became a 4.
Well, and in the new classification, they've now done away with the S and G, which from my standpoint, if it's going to be precision medicine, I think it's more precise to define the pauci immunes as opposed to lumping them together now and just ignoring that histologic difference. I mean, part of the thing we always felt was, ours was a prospective controlled trial, and they all got treated the same way. And as Ed always said, we probably overtreated the immune complex mediated patients and undertreated the pauci immune ones, whereas, in other studies, that Gary Hill had looked at, or, where they looked at other patients, the physicians were, treating them as they wanted. It wasn't based on a controlled predefined therapeutic protocol. And they may have treated patients with vasculitic lesions more aggressively than they treated the others. I mean, there's all kinds of reasons you can get into, but
I feel like we're still in the aspirin and dipyridamole world for treatment of lupus nephritis, and to have 20 years go by and not be more specific really has to do with, I think, how they're defined. And I know this will take longer to redefine it now and then move forward, but it has to be done at some point. Otherwise, it's going to continue to be MMF for all. For anybody who has lupus nephritis.
Well, people are getting into multi-targeted therapy, and now they're looking at other agents that are a little more specific.
No, but that's my point, is that if it'll be a class effect, then we want to know that. And
the problem is it's hard. There's enough bad studies of not enough lupus patients, and then you break it down into these subsets. It's going to even be harder to do. That doesn't change what you're saying and the legitimacy of your concern, but these things are really, really hard to do. Look at all what we got out of our 86 or whatever patients in the plasmapheresis trial, and there's been bigger trials, but there's a lot of smaller trials. It's not that easy to get that many people, but that doesn't change your point at all. And I think it's good. Our thought has always been that, thanks. Our point has always been that segmental necrosis is more likely to lead to a bad because it kills part of the glomerulus. It's whereas opposed to what we saw today, I mean, part of what I felt about MMF is that that was a glomerulus just chock full of cells without crescents or necrosis. I think this patient, would predict this patient would do better based on that. And you know, we project that segmental necrosis is going to lead to more CKD. And again, I don't know how well Steve's kind of commented enough on that very nicely, but I still think there has to be something to it. I really do. And it's a shame the way, you know, Steve said the precision medicine. We are in an era of precision medicine, and yet they took this away from us. I think that's really well put, Steve. I mean, I think that's like against everything we're going. We should be looking at these things as much as we can to target and know exactly what we're dealing with. There was a question in the chat. It says, do patients with 3 are more likely to be ANCA positive? I don't know that. I think that the patients that are ANCA positive more often have a 3, but I don't know if the other of that is true.
No,
Some of these patients will be MPO positive, but the overwhelming majority of these patients, when you look at them, are ANCA negative.
No,
And
that I
they're-
know, but the other way around is when you see an ANCA positive lupus patient, do they tend to be 3s? Or no, excuse me, do they tend to be polyimmune segmental necrosis? I just fell into the whole classification problem.
Yeah, they do. And
Okay, so I think
my
that's-
recollection is Vivette Nagati actually looked at these ANCA positive patients and described a whole group of them. But she specifically coned in on patients who were ANCA positive with lupus.
Yeah.
You know, we were
Yeah.
looking at patients irrespective of obviously, we didn't have ANCAs in all these. Ron Falk had run ANCAs on the serum, but the problem was some of the serum that they ran it on was after the patients had already been treated. So,
Yeah.
and if you look at other historic papers, about a third of the time, patients with lupus will have ANCA.
But
And in our
certainly-
patients, the ones that we tested, the majority of them were ANCA negative.
That's right. So you can definitely have the segmental necrotizing polyimmune lesion without an ANCA, but if you do have an ANCA, it's a little bit more likely you'll have that lesion.
So I don't know why you threw this up there, but the 4Q group was the group we said was the swing group. In one classification, it would be in the segmental, and in the other classification, it would be in the you know, it would be lumped into 4G or 4. And then we had our course, you know, the survival curves, depending upon which way you looked at it. I don't know if you put that in there, but this is like a Saturday Night Live Venn diagram. If you have to, I'm not going to do this because I get in trouble every time I do, but if you say things fast enough, it sounds like something else.
Yeah, Steve, I think we'll skip that. You
Yeah.
know, so I'm sorry, Dr. Glassick left. I hope he left because he had something to do. He didn't have a heart attack from the new Whittier classification. So Dick, we hope you're okay. I'd be curious to see what he felt about this. I know he hasn't always embraced that pure vasculitic lesion as well as we have. And I think you would have had a little bit more of an argument there. So it's interesting. Anybody else have any comments on this? As a great case, great discussion, Bill. I wish you luck with your future. This may be, you know, your 15 minutes of fame. Not today, but maybe you can write this up somehow and in an editorial somewhere and get some legs on it, because I think it's a really good point. And especially what you're saying is we're mixing prognosis with pathology, and I think that what we really need is a much cleaner classification based on pathology. Is that fair, Bill?
Yes.
Did you think this patient had podocytopathy? Would you call this on this patient?
Yeah, I would say they had a podocytopathy, they had a membranous, and they had a wire loop lesion. And we could
So
call
you-
the 4s the wire loop lesion, and we can call the 3s a vasculitis. We don't even have to
So-
say
Yeah.
focal or global. I think the other is focal, global, and all those are important pathologic features for prognosis, but they really shouldn't be diagnostic as much.
So I'm going to end it by calling this is a 3-5 little p.
No, 4-5 little p.
Oh, I'm sorry. Yeah, 4-5. Yeah, thank you. 4-5 little p by the Whittier classification. Thanks, everybody. The CME activity code is 486171, and let's see you guys probably next week. Everybody stay safe.